This is Michael from Blue Sky Bio, and I'd like to welcome everybody who's joining us for tonight's webinar presentation. This is the second presentation in the 2018 webinar series, and you can see the schedule of upcoming webinar presentations and access past recorded webinars via our website at blueskyplan.com. As usual, please make sure to enter your details into the webinar attendance form. The link is in the chat box next to the video screen. This way we could send you the CE credit for attending the presentation. The credits are sent via email, usually within 1 week of the presentation. If you have questions during the presentation, you could type them into the chat box, and we'll try to address them as we go along. Tonight, we have the pleasure to hear from Dr. Rick Ferguson, an international lecturer and educator, and really a leader in digital dentistry and guided surgery. He'll be presenting on the topic of updates on 3D printing and implant dentistry, single tooth to full arch. It's all easier now. Rick?
Thank you, Michael. And I'd like to first of all start off by thanking Blue Sky for the opportunity to present, as well as thanking Michael Salzman for all of his contributions, and also to my fellow presenters in this series, Danny and Corey and Baron, David and Michael, for their contributions to all of this technology and the ability to do some really amazing things with digital technology in our practices. So the topic is single tooth to full arch updates on 3D printing. What I'd like to do is go through and show how we're using 3D printing in our practice on a daily basis. We'll talk about the current printers we're using, and then look at some cases, looking at how we use it for a variety of different types of implant cases. So as some of you might know or might not know, we run a company called Implant Educators, and we run a comprehensive 7-month implant continuum with the University of Florida near Seminole, Florida, which is in near Tampa Bay. And we are able to take dentists from anywhere in the U.S., any U.S. licensed dentists, and they can come to our program and learn how to place implants, bone graft procedures, and restorative procedures. We also, we've been running that program for about 10 years, and we also just recently started, we're in the middle, towards the end of the first year that we're doing the program, and here's our list of speakers for that program. The same list of speakers also for our other program, which we're doing in conjunction with LSU Dental Implant, the Dental Implant Continuum there with their continuing education department. Dr. John Barksdale is a director, and I'm the co-director at this program. So it's a similar program. We're able to take any U.S. licensed dentist, and they can come down and do the same thing that we do at our Florida program. There's also a single tooth implant course coming up in Houston with myself and Dr. Barksdale. Anybody's interested in that as well. We run also a variety of other types of smaller courses, 1- and 2-day courses on a variety of topics that you see on the screen here. So go to our website if you're interested in any of these topics, and you know, you can certainly see the dates that we have available. They're not all run at the same time, you know, so there's some might be available now, and we're always constantly planning new courses. We have a new course that's going to be coming up called Digital Dentistry with 3D Printing, and a new speaker, Dr. Kurt Bally, who's going to be teaching that course. But of course, the thing that I am most proud of is that my wife, Dr. Catherine Ferguson, and myself have a small private practice in Davie, Florida, near Fort Lauderdale, where we do some pretty neat things with implants and digital dentistry. So if you're ever nearby, please give us a shout out, let us know you're coming, and we'd be happy to show you what we do on a daily basis. So currently we're using these 3 different printers. The workhorse in our practice is the Form 2. We use that. We have 2 Form 2 printers. They pretty much go nonstop all day, every day, and overnight, and we print aligners and models and such on that. The Robox printer, which is the original printer that I sort of adopted for dentistry, we don't use as much anymore, but every now and then we need to get a guide out quickly, or don't want to have to bother with the cleanup with the SLA type printers. That's still available. And then the latest printer that we've started using is a smaller printer, a little bit lower cost, really just for doing one appliance at a time, and that's called a Xiav. It's an open printer in that you can use any resin. You can even develop your own profiles for different types of resins. Now, we've gone through and developed the profiles for a variety of resins, and actually a lot of those resins are available from the Blue Sky Bio website. They're being sold as the Moonray resins, so those will certainly work in the Xiav printer. If anybody wants a budget way to get into 3D printing, that might be another option as well. If you look at the prints from, for example, a Form 2 printer, most printers will print at an angle for accuracy. You can print flat as well on some printers. What's kind of interesting about our work with the Xiav printers, we discovered it prints very accurately flat. So if you know anything about 3D printing, you know that the taller the object with the SLA type printers, the longer it's going to take to print. The nice thing about the Xiav, it's an LCD printer. It prints a full layer at a time. So printing flat actually speeds up your prints significantly. And we figured out that using a technique, which is something I actually have developed for the Robox printer, which is to print flat and create struts in the guide or whatever you want to print, that allows you to lift the guide off of the platform just by a small amount. You can adopt this technique if you're printing like on a Xiav printer. I think this should work for the Moonray printer as well, which I know Blue Sky carries. You're using a strut to lift the print slightly off of the build platform, which allows you to print faster and still keep the accuracy. 4 printers that allow you to print flat. Now, what's going to happen with SLA type printers like the Formlabs and the Moonray and the Xiav is the first layers are going to be over cured so that they stick nicely to the build platform and don't fall off during the printing process. This presents a problem though, because if there's any, for example, in the Form 2, there's a 3mm layer that's printed over cured, and that area you'll get distortion. That's why you want to move the print from the platform. With the Xiav, you have control over that dimension. So you can print however many layers you want over cured, and we found that we can print 10 layers over cured, and that's enough. So you only need to print or lift the model or the guide 1mm or more off of the build platform, and you'll still get an accurate printing without any over curing on the detailed areas that you need, such as the intaglio surface of the guide. So by adopting this technique of creating a strut, which I had posted a video about 2 years ago on YouTube showing how to do that, so you can find the video there. We can adopt that, and it's not supportless printing, but it comes pretty close. These struts are the supports, and we found that we could even print full arch guides using this technique on the Xiav. And like I said, this should be applicable to Moonray as well to help speed up your printing. For example, this full arch guide here, this is a screenshot from the Xiav software that comes with the printer. You can see it's going to take 53 minutes to print this full arch guide, which is actually pretty good. And you can see right there on the build platform that it's flat, but in the upper right hand side you can see that there's that 1mm layer that's over cured. It's kind of difficult to see in this picture. I have another picture coming up, but it allows you to print faster, and also you're not wasting as much resin during the printing. One little tip, you notice on the build platform there, the build platform scratched up pretty good. That's actually a good thing when you're doing 3D printing, because that makes the print stick a lot better during the printing process and not fall off and not have failures. So that's not a negative. in the picture that you see there down to the lower left-hand side where the build platform scratched up. So we've really taken this little printer to, some new heights. These are some of the prints that Dr. Renal Gonzalez has done with the little ZIAF printer. You can see the NextDent denture base, and then the teeth were done in the NextDent crown and bridge resin bleach shade, and also the hybrid on the lower left was done with the NextDent crown and bridge bleach shade. And then you can put in shading and painting soft tissue as a temporary appliance, for example. And then you see on the upper right the OrthoClear resin for making mouth guards, and then the Moonray model resin down at the bottom with some of the NextDent crown and bridge for doing temporaries and such. So it's a really neat little printer. So I'm not going to talk so much more about the printers at this point. We're going to look at some cases and how we're using these technologies. There's certainly lots of talk and videos and information on YouTube, and go to the Blue Sky section. You'll see a lot on the 3D printing as well. So everything we do in our practice is prosthetically driven, even though we do quite a bit of implant surgery. So everything that we do starts out with a prosthetic plan. And, that's how we teach implant dentistry. That's how we practice it. What we do need is we need a CBCT. We need a defined scan, and that will allow us to then design and plan and design a guide, 3D print it, and then execute the case. So what we're looking at is digitizing the patient in a certain way, merging DICOM images with defined scans and STL. And there are several ways to acquire those STL or defined scans. Of course, intraoral scans, stone models on a CBCT, VPS on a CBCT, and you could also use a lab scanner. So we are using two techniques mainly, which is the intraoral scans and the VPS, the CBCT of a VPS impression, and I'll show you why a little bit later on. We don't use a stone model so much, and that helps in efficiency because we don't have to pour a stone model. But I know several other presenters are using stone models. We just find that we don't need to with the CBCTs that we have. It picks up the VPS material very well. And by the way, Blue Sky recommends using stone model CBCT of a stone model and a CBCT of an impression in their protocols. So we're using all three, but what's recommended by Blue Sky is using stone models and VPS impressions. So we have CareStream 8100, which does a very nice job scanning different objects. It has object scanning protocol in the system. So we can scan a denture, we can scan stone models, we can scan VPS impressions and other types of impressions. And this is how you do it. It comes with a platform that you place. And a lot of the scanners nowadays, the different manufacturers are coming out with these platforms that allows you to scan objects. So you can scan a stone model and it shows up really nicely. It'll even pick a pretty close to the correct threshold setting. So you get a nice clean STL file from it. And we have their model software, so it goes right into the CS model software, especially for orthodontics. That's nice. Here's an impression, a VPS impression on a tray being scanned. And this is a resulting STL file that's created in the CS model software. What's nice is the model software will actually add a base automatically, and then you could print that if you need to. We don't end up printing a lot of models actually because we've moved so much towards the digital protocols in the practice that we're really trying to eliminate stone, and even printing of models we don't do a lot of. So that's what the scan looks like exported from the 8100. Here's what another thing that you can do. Depending on the field of view of your CBCT scanner, you can stack bite registration and the upper and the lower arch, or the bite registration and the upper and lower impression, which gives you a nice output. And then you can segment these out and actually bring them into occlusion in the Blue Sky software. And I have a video posted on YouTube of how to do that as well. So let's look at a case. this is Yana. She's 62 years old, female. She's been in a practice for a long time, and you can see her hygiene's not all that great, but she comes regularly for her recalls. And interestingly, I had done an implant on tooth number 6 area about 15 years earlier. She had a congenitally missing tooth there, and the primary tooth had exfoliated, and we did an implant there. And we knew that this lower tooth, at some point, her primary tooth here would exfoliate as well. And the minute it started getting loose, she called up and wanted to have an implant done, because the implant on the upper had gone so well 15 years ago, and it's still there. It's still doing very well. Still looks good aesthetically. So she came in, and of course, yeah, we're going to go ahead now and plan to place an implant there. So we bring all the data sets into Blue Sky, or Defined Scan, or CBCT, and you can see this is a tight space, and we're definitely wanting to use guided surgery in a case like this, because it really gives us the accuracy that we need to do the case properly. So we bring in the data sets, we plan the implant. It's a 3.0 diameter implant, a small diameter. And you can see that in this case, we're not going to be able to do at least we thought, not going to be able to do a screw retain crown, because the trajectory of the bone and such made it impossible to do, or made it so that we'd have to have the access hole coming out on the facial. And for a lot of patients, that's not acceptable. So we're looking to do a 2-piece here with a crown, a cemented crown, and we go ahead and plan the case, and then print a guide, and then go to the mouth, and now we're going to execute the case. So we extract the tooth, and the guide was designed for the extracted site. We place the guide, and we do a pilot hole, and we can see here that we're right on the money as far as being in between the teeth in the proper dimension. We place our implant, and because it had good stability, and we use an Ostel meter to test the stability, we decided to go ahead and fabricate a temporary, and that's what we did here, using a titanium base and light cured acrylic. We'll go ahead and light cured composite. We'll go ahead and fabricate a temporary. This is what it looked like the day we placed the implant. So the patient goes home with tooth, and you can see we're obviously keeping it out of occlusion and making sure that there isn't undue stress. So what you're seeing here is an overlay of the pre-op and the post-op. The pre-op plan is in red, and the post-op scan where the actual implant is in white. So we can overlay, and you can see how accurate this guide was, even in a tight space like this. I mean, we're off no more than maybe a quarter of a millimeter with our accuracy. So in situations like these, and here's a graphical representation, in situations like these, we definitely want to use guided surgery to give us the highest level of accuracy. Here's an immediate post-op scan of the temporary. You can see, and actually, I know people will be pointing this out as this video goes live. Yes, the abutment wasn't seated all the way because there was some impingement on the bone, and we did address that, but this is what the x-ray looked like the day we put it in. And here's about a week post. This is actually 10 days post-op. It's looking pretty good. And then this is the final restoration, actually at 1 year. Now, interestingly here, we did do a screw retain restoration. Even though it was a 2-piece, I was concerned about getting cement down below the tissue. So for this particular patient, we actually drilled a hole through the crown and used composite to seal the access on the facial. And the patient was actually quite happy with it. As a matter of fact, here's a 2-year post-op. This picture was actually taken today. Patient was in for her recall today, and we took this picture, and there's the composite. Doesn't bother her. She's happy. She doesn't even know the difference. So that's one case, that we're using, doing an immediate placement. Another technique we're doing is something that actually my colleagues and co-directors for the implant continuum, Dr. Dwight Pate and Dr. Arthur Acker developed a technique called the Packer technique. So Pate plus Acker equals Packer. The idea here is, we've done osteotome sinus lifts using the Summers techniques and other techniques for many years, but they were somewhat unpredictable because it requires drilling right to the floor of the sinus. And on two-dimensional x-rays, and even with a three-dimensional x-ray, sometimes it's hard to judge as you're getting closer, and you sort of have to look at the drill and see where you are. So they developed what's called a guided osteotome sinus lift using the Packer technique. The idea here is that by using a guide, you can get the drill right below a millimeter or half a millimeter below the sinus membrane, or staying in the bone, and then use osteotomes to just gently push the remaining bone in the Schneiderian membrane up, and using bone to pack as you go. You'll see here. So this is Jack. He's missing a tooth. Presents to us. You can see a significant defect there. So what we decided to do was do an implant placement with immediate bone graft lateral augmentation. He had a tooth extracted here for orthodontic purposes, and then he lost a second premolar. So the defect that you see there is mainly from his tooth extraction and then subsequent orthodontic treatment. So we take a CBCT image and we plan everything in the Blue Sky software. Here you can see the trajectory of the implant. So you want to plan your implant about a millimeter below the sinus floor. Now here we're planning to go in and use osteotomes to widen the site and also upfracture the sinus floor. And you can see there's a natural septum in the bone. So we're going to direct the drill towards that septum. So you don't, even though the implant's going to go in deeper than what you see here, that height of this planned or planned implant here is the actual height. You can see it's not planned all the way to the crest of the bone, because we want to drill it short. We want to drill short of the sinus floor, and we're actually going to direct it here into the septum. So we go ahead and lay our flap. We, of course, print our guide from the Blue Sky plan. We go ahead and reflect our flap, place the guide, and drill the initial pilot hole through the guide. And it's going to stop us just short of the sinus floor, directed into that septum. We're going to take advantage of that septum, bony septum in the sinus. We're actually going to use a piezotome here as well to do the prep for the implant. So we measure on the piezotome the actual length of that implant that we had planned before, knowing that if we stay at that length, we'll be short of the sinus floor as well. So we're going to go ahead and prepare our osteotomy using the piezotome tip, and now we're ready to do the actual osteotome sinus lift. We'll use some PRF membrane. So this is another thing that is really helpful in doing these internal sinus lifts, because the first thing you should put in is a PRF membrane. That will act as a cushion or buffer to prevent forces from tearing or breaking the bone too rapidly and possibly tearing the Schneiderian membrane. So we'll put a PRF membrane in, then we'll go in with the osteotome, and it's designed to go so that it goes into the surgical guide, and we'll actually push the membrane up using the osteotome with just hand pressure. We'll then keep adding increments of bone, going into pushing the head with the osteotome. And then once we've got the site lifted, you can see there in the picture on the right-hand side how we've created an osteotomy, and also we've pushed the bone ahead of it, the graft material ahead of it. So we have a nice balloon of graft material around the implant. And then we go ahead and place our implant to depth, which is going to be into the past the bony floor of the sinus. And that's what the final x-ray looks like. You can see we nailed it as far as directing the implant right into the septum I don't know if you can see my cursor here on the screen, but right into the septum to take advantage of that bony septum to fixate the implant. And then we do a lateral augmentation as well here using particulate material and collagen membrane and closure. And we've augmented now, not just internally, but laterally as well to take care of that defect. So you can see the final result here, the final CBCT. We've developed a nice bump of bone around it when you look at it from the lateral view. And here's the septum. We've directed the implant right to the septum. That's the beauty of guided surgery, very accurately. If you look in the axial view here, you can see the original bony contour and how we've grafted with the lateral augmentation. And then the best part about it, in this cross-sectional view, you can see that we have actually lifted the Schneiderian membrane up the medial wall as well, which will give us a good source of osteoprogenitor cells to come in and regenerate new bone around the apex of that implant. So that's the Packer technique developed by Dr. Dwight Payton, Dr. Arthur Acker. This is a great way to do a internal or crestal approach sinus lift today.
Can I jump in with some questions?
Sure.
Okay. Are you making all your restorations guided and screw retained? Question mark. Even if the screw channel is on the facial? Question. Just to
No.
be sure that just to be sure that your restorations don't have any excess on periodontal tissues. Brilliant.
Well, we try. If the patient will accept it. In this case, the patient accepted it. If the patient didn't accept it, I would probably have done a cement-on crown on the custom abutment. But yes, with guided surgery, it allows us to do the vast majority of our cases now screw retained. Even in the premaxilla, sometimes we can augment the bone that allows us to place the implant in the proper trajectory so that we can do screw retained. So yes, the answer is that's our goal. Do we always meet that goal? No. So moving on, one of the questions I get quite often, and from students that we've trained on guided surgery, they'll send us a CBCT to look at, and it looks like what you see down here in the three-dimensional view. You see all this X-ray scatter, and they want to know, well, how can we make a defined scan and merge it and get an accurate guide? So there are several ways of doing this, but mostly they require doing something called a scan appliance. And previously we had to have these made in a laboratory. Well, I've developed a technique here, which I'm going to share, which is using something that every dentist already has in their practice, which is typically vinyl polysiloxane impression material and plastic trays. So this is a scan appliance technique for patients that have a lot of metal or zirconia that's going to cause beam hardening and X-ray scattering where you can't see the teeth properly to match up your defined scan. This works really well. Now, we sort of taken it to the next level here by using glass beads that are readily available on Amazon. If anybody wants to know where to get these from, just send me an email and I'll send you the link on where to get these. You can buy these, about 3,000 of them for about $30.
I think we have them on our website, actually.
You have the stick-on ones. So yeah, you can use the stick-on ones. Those work great as well. I find these stay on a little bit better because we're super gluing them to the tray. So what you do is, and our assistants do all of this for us. They're well versed in this technique. So you can use a number 8 round burr and just drill some holes in the tray. It's important to keep and then glue the beads in. It's important to keep the beads away from the line of scatter. What does that mean? You notice that we try to keep them down by the rim and on the top of the tray where the occlusal surfaces are, and even it going into the handle. These beads are radiographic markers that are going to be used to align the scan to the patient's jaw in the Blue Sky software. So by gluing these in, and you want to put a lot of them. We usually put about 12 on every tray. This allows you to because some of them are going to get wiped out by the X-ray scatter. That's just going to happen. So the more you have, the more points, the better. but the line of scatter is going to go horizontally. So you want to keep in mind where the crowns are. So anywhere that the crown is in the line of scatter or horizontal to the projection of the beam, it's going to wipe out your radiographic markers. And this is a mistake that I see a lot of people do. They put the beads right in the middle of the tray. Then when they take the scan, the markers are all, you can't see them on the scan. So put them on the top of the tray or down by the rim, even further down if you can than what you see in this picture. So you're going to line the tray with a layer of VPS material. This is important. You're going to line it with about 2 millimeters of VPS material. Let that set. And what you want is you don't want the teeth touching the tray and creating holes in the impression, because then you won't be able to invert the image properly in the software into a positive image. So no holes in the material. Let this set. Just put a 2 millimeter layer in. Let it set, and then fill the tray with new material. It should be the same consistency and the same type of material. We use a medium body, so don't mix a light body with a medium body or a heavy body. Just use one mono material, such as a medium body. So after this sets, you're going to fill the tray again and then put that in the patient's mouth and let it set. And you're going to immediately walk over to your CBCT machine and scan the patient with the tray in their mouth. Once that's done, you take the tray out and you're going to scan the tray by itself. If you have a platform that shows up radiographically, you can use a foam pad to create separation between the impression and the platform. So make sure that there is separation, or else this technique might not work so well. So once that's done, you can take these data sets in, these two data sets, and they're two DICOM data sets, and merge them in the Blue Sky software. Now, I have a video here that's going to show how we do it. So you brought in your jaw scan with the tray in the mouth. You're going to bring in now your impression scan, but bringing it as a scan appliance. The Blue Sky software is going to bring it in and show you 4 screens, and you can segment out what areas you don't want. Oh, by the way, there are upcoming speakers in the rest of the series. So you're going to segment out the areas that you don't want, and you just want the impression. Hit OK, and then the software will open up 4 screens that allow you to change the thresholds so that your glass beads show up, and you're going to make sure the orientation is correct. Line up your images so that you can start matching up your points. So here you can see we're going to choose points on both sides, and that allows the software then to merge the 2 images together. You'll see in a minute how that comes together. In this case, we actually chose 9 points. I don't believe we chose all the different points that were available, but 9 was enough. You click update, and the 2 images are merged together perfectly. Now you go ahead and you can check that and then hit OK. That brings it back into your main windows here, and you can see now if you turn on the hint, you can actually see how the 2 images are aligned. What you're looking for here is the lines in the hint to line up with your impression, because the impression will show up in this image. And you can see if you look down here, you can see the glass beads as well as we go through the slices and how the glass beads are matched up properly as well. Now, you'll see a gap here down at the bottom. That gap is a tray, because a plastic tray doesn't show up radiographically. So right here, you can see the glass bead, how it matches up with the 2 images. And that's how you know that the images are aligned properly. Here I'm outlining, showing you how the image of the impression is lined up with the defined scan or defined impression now. Now, this is great, except now we need to invert this into a positive image, and that's coming up on the next video here, which shows how we can use this technique, which I developed a couple of years ago and is now incorporated in the Blue Sky, to invert the image on the scan. It's aligned to the jaw. Now we just need to invert it. So you go to model manipulation, click Model Reversal, Show Limiting Curve, Draw Limiting Curve, and you're going to draw your curve. Make sure you go way outside because you do want to get past the undercuts in the tissue. So here we're going around the arch, and then of course, you know, if you use Blue Sky, you don't have to match up the lines perfectly. You click Edit Curve, and then you can manipulate the line, the little balls, and put them where you want them to go. So once that's done, you can now go ahead and click Create Inverted Model. The software is going to process, and it's going to give you an inverted model. And then you can look at that and turn off the impression scan, and then here you have a beautiful inverted model. Now, this model is only going to be as good as your impression. You can see there on the right premolar, there was a pull in the impression material. It's a positive, so it's not going to affect us making a guide with this impression, so it's fine. And what we're doing here is changing the color so that it shows up a little bit more clearly. And obviously, it's going to be matched up perfectly because the impression was. It's just an inversion of the impression, or what we call a digital pour, basically. So once this is done, now we can use that defined scan. Even though this patient had a lot of zirconia and metal crowns, we can use that defined scan to go ahead and create our do a prosthetic tooth in place and plan the case for a single tooth implant at the number 3 position. I had already done that on this case, so we'll just click the buttons on and show you the trajectory of the implant going through that prosthetic tooth. And of course, you can bring in the opposing dentition and make sure everything's lined up accurately as well. And then the last step is to go ahead and design your guide. And I love the new window functionality in the Blue Sky software, which allows you to put in a nice window for visualization of seating of the guide. So that's what we did here. And there's our guide ready to be exported and 3D printed. Of course, you can also imprint using the software, the patient information and the size of the implant and such. And that's what we did. So this is ready to be exported, printed, and now we go to the actual patient, and we're going to lay a very minimal flap here. We could do this case flapless as well. I'll show you another case a little bit later. We drill with the whichever kit you're using through the guide, place our implant, and here is the post-op CVCT showing an accurately placed implant exactly how we had planned it using the pre-scan, the pre-surgical software. So some single tooth cases. Let's look at full arch cases now.
Can I jump in with a question?
Sure.
Do you see any difference between a model scan plus DICOM versus 2 DICOMs with your inverted technique?
We don't. Now, we have calibrated. There's a technique on calibrating it, and that's on Hiroshi Takagi out of, I believe, Toronto, developed that technique after. It's an additional step. But once you do that once, if you use the same VPS material every time in the same settings to scan it on your CBCT, you should not have to do that calibration again. So Hiroshi has a video, I believe, on YouTube on how to do that one-time calibration as well. If anybody has any questions on that, they can email me. I'll send them the video how to do that as well. We have had very good success with using the VPS versus the stone model scan. I think for people who aren't calibrating the VPS impression, that could be an issue, you choosing the threshold. But actually, I've found with the recent updates to Blue Sky that it picks the correct threshold very well. So we don't even bother looking at the threshold anymore with the, maybe you can comment on that, Michael, but I've been very happy with the threshold that the software automatically picks. I don't know if any work was put into that, but it seems to be.
Sure. It should definitely be checked in the first, couple of cases, but definitely work into that.
All right. So yes, we found great accuracy from a stone model versus VPS. Some people like the stone model technique work better. But of course, the fewer steps we have to do, and if we don't have to pour a stone model, that's great too. So these are the stick-on beads that are sold on Blue Sky's website for doing the denture technique, or the scan appliance technique using a denture. Um, Blue Sky has a really great feature. It's the one-click denture guide. And I'll show you how we use that now with a little bit of modification. So it allows, what you can do is scan the denture by itself with the beads, and we actually, and then once you bring in the data sets, the two DICOM data sets, one of which you're bringing as a scan appliance, just a one click, it will create basically a guide from the denture. So let's look at a case. This is Kathy's case. She's missing her upper teeth, and she wants something fixed. And we're going to do the lower teeth as well. So we actually did a scan of both dentures at the same time. You can see the glass beads in this image. This is a panoramic projection from her CBCT. But we'll just look at the upper for now. So the thing with her case is finances were a little bit of an issue. So we're not going to do this as an immediate load case, like a teeth in a day case. We're going to stage it to help out with the finance. If I'm doing a teeth in a day case, I have to bring a technician in, and it's more steps, and frankly, it takes a whole morning to do a case like that. So this is a way to have a little bit better efficiency, and we can do it if the patient's willing to continue wearing the denture for a little bit longer. We can do it in this fashion. So we scan the patient with the dentures in the mouth. Here's what the patient looks like. Here's the denture. In our case, we actually glued the glass beads to the denture. We find that they stick on really well. Now, people are also concerned about damaging the denture. These pop right off, and then you can polish up the denture. But most of the time, you're converting these patients to a fixed prosthetic anyways, or making them a new denture. So it doesn't really matter, even if the denture gets a little bit damaged. But we haven't had any issues with the patient, with the denture getting damaged. But you can see where we put the glass beads on the palate and outside. Now, in this situation, we're not concerned about X-ray scatter because there's no metal in the patient's jaw in this particular case, because they're fully dentulous. So we bring in both data sets and merge them like we showed before, using the 4 screens and picking the points, matching up the glass beads. Planar implants, and in this case, you can see the 2 distal implants are going to be planned at an angle. And the implants, especially on the right-hand side, are going to be quite deep in the bone. You'll see in a minute how they ended up. This is the one-click denture guide that's made from the software. And what you're seeing here is now we're put this in the mouth, make sure the patient bites down and seats it into the proper position. And we've got lateral fixation pins to secure it in that position. And then we're using 3 lateral fixation pins here, and then we can go ahead and place the implants. In this case, we did it flapless. We actually just drilled right through the tissue. The 6 sites, you can see the distal site there going in, and this is what it looked like actually after all the implants were placed. So the implants were placed through these little tiny holes. Drilling was done, and the implants were placed through these little tiny holes. Very atraumatic. It's a very easy thing to do, and the whole surgery probably took about an hour. Again, maximizing our efficiency. Now the patient's going to go home with their denture, but what's nice about doing it this way, and here's the final X-ray post-op of the implants in place. You can see they're all pretty much subcrestal. So the patient can continue to wear their denture on in a situation like this, and the bone above the implants is protecting the implants while they integrate. One of the biggest reasons for failures that I see, especially young dentists getting into implantology, is they place implants under dentures, and the dentures end up beating up the implants, even though they will sometimes do a two-stage and have soft tissue, the forces can get transmitted down to the implants. But if you leave bone above the implants, that's not going to happen. So the patient can continue to wear their denture and the implants don't get affected too much. Once they're integrated, we'll go back and actually lay a little bit of a flap and do the bone reduction at that point. And this patient's going to get a fixed zirconia restoration on these 6 implants, the 2 being distally angled to avoid going into the sinus and avoid having to do sinus grafts. So another technique another way of doing this is what I call the dual scan inverted denture tissue supported guide. It's similar to the technique I just showed using the one click. A little bit more work, and you do have to take one of the files out to MeshMix. But if anybody wants to see how that's done, they can go to YouTube and do a search for that, and they can see the full video how to do that technique. The one advantage of doing this technique is that the guide is not as big because the teeth aren't in the way, and you can vary the thickness of the guide. So it's a little bit easier to get into a mouth, and especially if a patient can't open very wide or they have opposing dentition, and to get in there with your drills and such. So that's another way to do it. This ends up with a denture, with the guide being a little bit thinner than the denture guide, but it does require a little bit more work. So that's another thing that's possible. Another way of doing cases for full arches is what we call sequential guides. Because we are printing guides, our own guides in the office, this is very easy for us to do. And let's look at a case to really illustrate how this works. This is Marty. He has a terminal dentition. We're going to take out all these teeth and do 6 implants on the lower immediate load teeth in a day. So we go ahead and plan the case in blue sky. 6 implants. You can see we can parallel the implants so that the restoration will be pretty easy. And again, here we're doing the implants subcrestal, below the bone, to maximize the amount of bone around the implants. Especially, we want to get down below, pretty much down below the sockets. So this is your typical teeth in a day type of case where we're doing bone reduction. And you can do this with a bone reduction guide. You can do it, for example, with an in-sequence guide. It's a lot more costly to do it that way, and you have to lay a much bigger flap to get a bone reduction guide in. So we like to do it, if the patient has enough teeth, we like to do it this way. There is one big advantage of having a tooth-supported guide as well, is that there's been some studies that have shown that teeth-supported guides are the most accurate compared to soft tissue-supported guides. I don't think they compared it to bone-supported guides where bone reduction was done, but certainly bone reduction guides will be very accurate as well. But in order to do a bone reduction guide, you have to do a bone segmentation. So our preference is to leave whatever remaining teeth are in place and do digital extractions and make a sequence of guides. And we'll walk through the sequence here in a minute. So the first guide, we plan all the implants as if the teeth weren't there. Now the first guide we're going to design, we're going to do digital extractions on the 3 anterior teeth, and we're going to place implants in the 2 distal positions and the 2 most anterior positions. This guide is going to fit on the remaining 3 teeth and also the soft tissue in the back. So this is the first guide that's designed. Once this guide is used to place the first 4 implants, a second guide is going to be designed. And this is all done, of course, ahead of time. The second guide now, we're going to digitally extract the remaining 3 teeth, and the second guide is going to be designed to fit on the soft tissue, but we can actually fixate this guide to the first 4 implants that were placed. And let's go through and look at how this is done. So here is the case again where we started. We extract the 3 teeth in the anterior. We place the first guide, we drill and place 4 implants. Then we extract the remaining teeth and place the second guide. The second guide is fixated into the first 4 implants that were placed. And now we can drill the additional 2 sites to place our additional implants. This is what it looks like after all the implants are in place. You can see we did a minimal flap, And actually, at this point, through that minimal flap, we can go ahead and do our bone reduction and place our multi-unit abutments. So the multi-units are placed after the bone reduction. One of the things we'll do is we'll put cover screws on to protect the top of the implants when we do the bone reduction, but it's very easy to do a bone reduction down to the level of the implants. If you want to know how deep to do your bone reduction, just plan it so that your implants that are at the proper level, and then do the bone reduction down to the top of the implants. And once the multi-units are in place, we can go ahead and suture. Here we put some caps on some of the multi-units, and this is what an immediate post-op scan looks like as well, of those implants in place. And then we'll go ahead and put telescoping abutments on and pick up a denture that was made ahead of time with the holes in the correct position. Now, the denture was made with the holes in the correct position for the pickup because the laboratory was sent the STL file of the guide. So the guide was used to make the denture, so the lab would know where the holes would be. So we don't have to do that chairside. The holes are already pre-drilled. And we usually bring a lab technician in to do this because they're better at it than I am. So the lab technician will actually cold cure acrylic onto the telescopic copings and then cut them back. And we now have a screw retained prosthesis that's very solid, very strong. Because what you don't want to have is this prosthesis breaking during the period when the implants are integrating. This technique works because of cross-arch stabilization. You don't want any of the implants moving, and you don't want your prosthesis fracturing. So that's why we bring a lab technician in to make sure this is done properly. This is the intaglio surface. You can see our copings are processed nicely, and the patient goes home with a fixed restoration same day. Okay, so that's called a sequential guide, and we've used that numerous times to do cases that, for same day. And again, low cost because we're doing it in the office. I think the total cost of, the export from Blue Sky and to make the two guides was certainly less than $100 with all the sleeves and such. So a low cost way of doing all on X case, same day in your office. Now, what you should also do is print the second guide or the last guide that you're going to use, print a second one, because that can also be used as your final impression tray if you're doing an analog impression as well. Because those implants are going to be very close to the planned positions, and you're going to be able to use that as your custom impression tray. So that's a little clinical tip there for you. So other things we're doing, sorry, go ahead.
What torque values do you expect when doing guided technique like the case where you use the two sequential guides?
So it's going to be no different than if you were using, like a bone reduction guide. You're going down here in this particular case, down into the basal bone. So you expect that you're going to get good torque values. Our torque values are typically in the high 70s. In the maxilla, sometimes not so much. And, for example, we recently had a case in the maxilla where we placed 6 implants, but one of the implants had a low torque value. So we did not attach that implant to the prosthesis. And it was actually one of the distal implants. So we just cut off that tooth on the back of the prosthesis, but the patient was still able to go home with their fixed prosthesis that day. We don't want to overload our implants, but certainly in the mandible, we can get good torque values. And most of the time in the maxilla as well, they're, in their high 70s. Now, that all goes back to your drilling technique as well. You don't want to over drill the site. So we're typically stopping one drill short in the maxilla so that we don't over prepare the site. And then we use the implant to do sort of bone compression. Okay. Hopefully that addresses that question. So some of the other things, just to wrap up here, that we're doing with 3D printing in the practice, we're making night guards and other mouth guards and other appliances. There's different software out there to do it. This is ExoCAD, and I know Blue Sky is now carrying exocad. You can do it with Blue Sky software by basically creating a surgical guide around the teeth. But if you have more sophisticated software like exocad, it allows you to actually grind the bite in and make a very accurate bite splint for your patient. And we can 3D print these for probably around $3 using resins that are Class 2A available resins right now. So this is another option for people who are doing night guards, 3D printing in office. And here's our little 3D printing setup. You can see we've got 2 printers. We've actually got more printers now. This is an older picture, but not a lot of space, to get started. We actually converted a little closet into a 3D printing center, and you can see some of the night guards here. We were actually printing these for a course, so it's not like we print this many night guards at one time, but they're very nice. And we print these at 100 micron accuracy, so you're saving time on the printer. You don't have to print down to 50 micron with these. And then the last thing is that's really become a big part of our practice is in-office clear aligners. We had done Invisalign and ClearCorrect for many years, and because of the cost, we didn't get great case acceptance, and now we're able to do these at a very low cost in office, sometimes as low as $150 a case, which allows you to reduce the cost and get more patients to accept this treatment. So this is in-office clear aligners. This is a case by Dr. Gonzalez. Between he and I, we've probably done 250 cases in the last couple of years using these techniques. 12 aligners, 2-week intervals, 6 months. Here's another case where he was able to correct a crossbite. 22 upper aligners, 19 lowers, 2-week intervals, 11 months, $163 in cost. He had to do 2 revisions in here, but they're easy if you're doing it in the office. You have more control, and that's the key. Now, we've been doing orthodontics also for over 20 years in our practice, conventional orthodontics with brackets. And now we're finishing every case using clear aligners because it's so easy and it's so accurate. The hardest part about finishing an orthodontic case is finishing. Finishing a case takes the longest because you're trying to micro move the teeth to the proper positions and get them all aligned and so on. So in this case, for example, with Abby, this is where she started. We had her in brackets and wires for a period of time, and about 3 months before she's ready to be finished, we'll go ahead and switch her over to clear aligners. And we plan the case, treatment plan the case, print the models, fabricate clear aligners. And this has become such a big part of our practice that we pretty much had to hire somebody just to fabricate these in office. That's a good thing though. And we finished her using clear aligners, 6 aligners, 3 months, cost of about $50. And again, you're getting, it's an easier process. The patients love it because they're getting out of the conventional brackets and wires earlier. And then these will end up being like their final retainers as well. Okay. And that sort of segues into the next webinar in the series with Dr. Grutter talking about Blue Sky Plan and digital orthodontics. And then the other speakers, Corey and Michael and David, will finish up the series. So again, I want to thank Blue Sky, and I'll leave with this quote from Albert Einstein. Some of what I showed might seem complex. It's not as complex as you might think once you get started doing this. I encourage everybody to get into it. And as Albert Einstein said, everything should be made as simple as possible, but not simpler. And again, I want to thank Blue Sky for giving me the opportunity. Here's my contact information if anybody wants to reach out, any questions and such. Thanks again.
Okay, well, I definitely want to take this opportunity to thank you. We've been getting comments throughout the presentation about the quality of the presentation, the amazing depth and breadth of the knowledge that you're presenting, and what a great presentation it is or it was. So thank you very much for taking the time and sharing this information with everybody who attended.
Well, I think I finished up right on time for a change. So we'll take any questions.
Okay, so let's take a few of those questions. On that previous case that you presented earlier, how did you fixate the second guide?
So there are tools available. You can use actually impression copings. With that particular system, they actually had a tool to fixate the guide to previously placed implants. So some systems have that, others don't. That particular system I was using, that tool is compatible with Zimmer compatible implants. So if you want the information on that, just email me. I'll tell you where you can get that particular tool. But I know there are many companies now making tools like that, and I believe Blue Sky might have something as well that allows you to do that. Maybe you can comment on that. You can use impression copings as well. With the long screw on the impression coping, that's one thing you could do as well.
Okay. A bunch of questions came in regarding the different types of printers, the printing times, and the printing costs. Can you just give a brief summary and overview?
All right. So probably the lowest cost one to use would probably be the Robox as far as printing surgical guides at the lowest cost. I mean, you can print a surgical guide as low as $1 on that printer. It's sort of ridiculous. So that's one thing. We are moving a little bit away from the Robox because there are a lot of moving parts to it, and it requires some amount of technical knowledge. Moonray and Formlabs are probably the big ones out there now as far as ease of use and support. That's very important. And being able to print multiple things at one time. If you're going to do clear aligners, you're going to need a bigger build platform than what the Xiav or the Formlabs, what the Xiav or the Robox allows. You can't do clear aligners with Robox. It doesn't have the resolution. So as far as costs, when you factor in your time and such, it doesn't. I don't really think it's a big issue as far as the cost. With the Formlabs, the Moonray, and the Xiav, they use similar resins. The Xiav uses a Moonray resin. We've worked out the settings for the Moonray surgical guide resin and Moonray model resin. For a surgical guide on that printer, you're probably looking at about $4 or $5 per guide to print, or probably less. Depending if you're printing it supportless, like using the technique I just showed, where you don't have the support materials, that's going to save your resin as well. So typically, after your initial investment in the printer, you're going to be looking at about, less than $5 to print a guide. And then you'll need to buy sleeves, which you can get on the Blue Sky website. They're about $7. And, we reuse those as well. So that reduces your costs significantly. The cost of the Xiav printer I put on there is about $1,200. That's with their what they call a dental package, where they'll log in and set the printer up and give you some training on it. The Moonray printer, I believe, is about $4,000. Formlabs actually just reduced the cost of their printer down to $3,300, $3,350, I believe. With the Formlabs, you do use their resins. It's not a completely locked system, but you're going to get the best results with their resins because they've worked out all the settings in there as well. Just like with the Moonray, they've worked out all the best settings for their resin. With Formlabs, though, they do have an open mode, which we use, and we can buy resins as low as $60 a liter to print in the Moonray and the Xiav printer for printing clear aligner models or other types of models. The surgical guide resins are the most expensive. Those will run you $250 a liter up, but those are definitely certified for intraoral use. And then the Ortho Clear, for example, and the LT Clear from Formlabs are for making orthodontic appliances and night guards. So those are going to be a little bit more expensive. Those appliances are probably going to run you again in the $3 to $5 range because you're buying the more expensive resins for that. But you have to use those, especially the Ortho Clear material, for long-term intraoral use.
Okay, so I think we're pretty much out of time.
Okay.
So thanks again for the presentation. I'd like to thank everybody for attending, and all attendees should make sure to put their details in the attendance form so we can send you the CE credit. Stay tuned on our website regarding additional presentations that are coming, and we have a lot of interesting and fantastic updates to the software that are going to be coming out in the next couple of months. So we'll be updating regarding that as well. Rick, thanks again. And everybody, thanks for attending tonight's webinar presentation. We hope to see you at the next one as well.
Thank you.